Welcome. I am William Sonstein, Dr. William Sonstein from NSPC Brain and Spine Surgery, and this is my compatriot and my spine bro.
Happy to be here, Dr. Richard Obedian of Island Spine and Sports.
So this is our sixth broadcast of our podcast, and we are welcoming here our special guest today. We have Dr. Murat Absholamov, and we have Charlie Wernicke, our esteemed members and directors of our IOM Solutions practice, which is part of, as a subsidiary of NSPC.
And IOM stands for?
And the IOM is Intraoperative Monitoring.
Yes, which is critical in spine surgery.
And we use our monitoring company all the time. And we are very happy to have them here to discuss why I believe, and what Dr. Obedian I'm sure also believes, is the importance of having them in terms of patient safety and offering the most safe situations for patients when they have surgery. And we're here to hear about their training, their backgrounds, why they went into what they do, and what types of things they can provide for our patients. So, Murat and Charlie, please talk about what you guys do for us.
Well, thank you very much for inviting us. It's a pleasure to be here. It's very nice, pleasant.
This is a real professional kind of situation here.
Yes, it is.
You wouldn't even know it here.
And you're absolutely right. Intraoperative monitoring services is designed to provide a most safe pathway, most safe possibility for the surgeon to accomplish surgical goal and help the patients. And that's most important role of intraoperative monitoring solution. And for spine surgeries, specifically when the thoracic cervical regions involved, when Kodak-Weiner syndromes involved, it's very, very important. However, I don't want to say that's for the discectomies or fusions. It's not important. It's very important for positioning, for systemic issues that may occur during the surgery. It's all based on physiology and reaction of the patient body to what actually happening in the operating room. And neurophysiologic services designed and serve to inform the surgeon of the stage and state of the patients in a very moment, correlating with what actually surgeons do at that moment. And that's very important, and I hope it is very helpful.
Oh, it is. So you guys are both basically neurophysiologists.
Yes, we are.
Right? So tell me about the training to become a neurophysiologist. You go to school for that, and you've got to be licensed by the state.
And how long have you been involved with NSPC and our practice?
How does that work?
Working with us.
I've been here almost 14 years with you guys, and you were another...
You have been second hire, I do believe.
Correct.
Yeah.
Right. Were you the first one we hired?
I was the first one, September 2009.
And where were you guys before? What did you guys do?
So my training goes back to Russia, 1995. I got my PhD in neuroscience, neurochemistry, neurophysiology. Then I came here for a postdoctoral position at NYU, working with on physiology of dopaminergic neurons and substantia nigra at NYU School of Medicine, Department of Neurosurgery. Then I moved to Mount Sinai at Neurosurgery, where I was assistant director of Intraoperative Monitoring Division. And then 2009, NSPC invited me to set up the division. And since then, we are together. As for training, official training, it's been time when neurophysiological and intraoperative monitoring training basically has been on the job. You have to come in and you have to watch, you have to observe, you have to read a lot, lots of papers, lots of articles, lots of textbooks.
Isn't there a schooling before you become a neurophysiologist?
No, but nowadays you have several schools that are offering basic knowledge in intraoperative monitoring.
Did you go to school, Charlie, for this?
So when I first started, it was they would hire someone with a science background and then teach you in more of an in-house program through a company what you would need to know.
How long does it usually take to get qualified?
They give or take about 1.5 to 2 years.
Is there a test to take after you've
After you have to witness so many cases, I think the number was 150.
150, yes.
And then after you witness 150 cases, you qualify to sit for your boards for your national certification.
there's a board certification?
There's one national board certification.
You guys are board certified.
Yes, we are.
Everyone in our company is.
And how many people now are in the company that monitors the patients?
We have
12.
12 technologists, and then Marat makes 13.
And then also behind you, you're in the operating room doing the hands-on work, but also behind you, there's also a neurologist who is
There's a neurologist.
yes,
who's doing it, who's doing the interpreting the
Who's
data
who's off-site,
in real time,
Correct.
but in real
The
time.
real
And-
time-
And you guys have
real-time
constant
interpretation.
communication with the
Multiple
neurologist.
forms
plus
of
the
communication.
surgeon, plus the anesthesiologist. So there's really multiple components that you got to deal with because because there's really different types of monitoring as well. There's intraoperative SSEP monitoring, which is sensory.
Yes.
Somatosensory evoked potentials, there's motor evoked potentials, and then there's also
EMG.
intraoperative EMG, which is useful for insertion of pedicle screws.
Why don't you guys explain some of the things that you guys monitor? I mean, obviously you guys monitor the spine stuff for us, but you also do brain monitoring for the other guys in my group that do brain surgery and things like that. Obviously we don't do that, but I guess in terms of what we're doing right here, let's talk about spine surgery and what are the different monitoring options you have and why it's relevant to what we're doing.
Well, let me just go slightly back to what Dr. Obedian mentioned. Yes, there are two components of our services. One component, very important, the technologies in the room, hands-on. Absolutely, it's a great definition. And the second is certain as well important is the supervising physician who is remotely watching the data that we acquiring from the patient. But the third component is that our communication with surgeons, with anesthesiologists, and basically with everyone in the room, because if something is deviating from our baseline or controls, so we're communicating with everybody. So that's like I would say 3 key components of what we do.
What is the advantage of what you're doing, and what exactly are you looking at when we're doing our routine types of spine surgery?
Routine types of spine surgery, we're monitoring sensory system, which everybody has, motor system, and we're monitoring those systems by several modalities or several options, different tests. And Charlie, you want to start with SCPs?
We'll start with SCPs.
What are SSCPs? I mean, for those who don't even know what these technical terms are, EMGs, SSCPs, motor evoked potentials. These are all types of very technical terms. Let's try to put it down in very simple
Perfect. We'll start from the beginning.
terms.
Sensory, the spinal cord has 2 different portions. You have the sensory portion and the motor portion, the front and the back of the spinal cord. So you start with, you send a signal from the end of your arms, the end of your legs, and send a signal all the way up the spinal cord. If you think of it one way, you're looking at traffic on the highway. If something happens somewhere and you get a backup, we're essentially making sure that that traffic is flowing freely from point A to point B. If you're working in the middle of that, we can monitor to make sure that nothing is getting damaged along that pathway.
So while we're doing our surgery, you are monitoring
Correct.
to make sure that what we're doing is safe. We're not causing that traffic to stop.
Right.
Correct.
The sensory columns are more dorsal.
Dorsal, they're on the backside, which is on all the lumbar cases. When you're coming in from the backside, you're working right along that pathway.
Dorsal
Right,
column
but-
pathway.
When I was in training, we did a lot of scoliosis at Hospital for Special Surgery. It was really important, and all we did at that time was SSEP monitoring during scoliosis correction. Because if you overcorrect or you do too much, you can theoretically cause changes to the spinal cord. Now, what we did at that time, because we weren't really doing MEPs or motor evoked potentials, was we would actually wake the patient up intraoperatively after the correction was performed and ask, usually it's a teenager, ask them to wiggle their toes. Now, it isn't as barbaric as it sounds, but it's called the wake-up test. And the patient's actually awakened during the surgery to see if their motor function is intact, because all you're checking at that point is sensory. But now with MEPs,
We don't have to wake them up.
you don't have to wake them up anymore. Do you still do
Or do-
wake-up tests, or if there's a
I
question?
haven't done a wake-up
when-
test in forever.
When do you do
few
wake-up
people-
test?
Very few people do
Very
wake-up
few
tests anymore.
people.
The
It's kind of an
benefit,
antiquated sort of
Agreed.
Older
The
technology.
benefit of monitoring is that you don't have to do that. So when you think of a wake-up test, you have to pause what you're doing. Anesthesia then has to change their whole regimen and wake a patient up. Now, some patients could wake up faster, some slower. So you could theoretically add 2 hours to your day of
Not only that, but it
I'm
can be
always,
quite
wake up
traumatic
stress,
to be woken
trauma.
up. And
Wake up
who knows what
test
you're
is
going to
risky.
remember.
And the
You're
patient
set.
can remember what happened.
It's a risky test as
So
well.
it's, that used to be the gold standard for
you
checking
avoid-
motor function,
you
but I think
avoid
now MEPs is replacing it.
unnecessary risks by
you're-
using MEPs and SCPs specifically for scoliosis surgery.
Now, when you do SEPs, and we'll talk about motor evoked potential as well, the anesthesia has to be different as well. So the anesthesiologist has to be intimately involved in terms of
Absolutely.
what types of anesthesia they can give, and there's certain inhalational anesthetics that they can't give, and they've got to give more intravenous sedation, right?
There's a whole different regimen. So when our day starts, not just when the patient comes in the room, we have to talk to you ahead of time to know what you want for that particular day, and we come up with a game plan. From then, we go to anesthesia and come up with a game plan. Well, if you're looking for this, there are certain medications that they can and can't use for certain procedures.
Let me just say, so we were on sensory before.
Yes.
So does the anesthesia basically remain the usual type of, of anesthesia that you would give for, let's say, a lumbar laminectomy or for a cervical laminectomy? How would it change, by now adding motor?
Anesthesia, say for lumbar case without motor evoked potentials.
Do you use motor evoked potentials for lumbar?
We
Usually it's for spinal cord, right?
we usually, well, in our practice, some surgeons do use motor evoked potentials for lumbar cases. Some surgeons don't. It depends on the patient conditions, the level of the lumbar surgeries, and
Like if it's higher lumbar, they would
You're
use
at the
motor.
level of conus, maybe at the level of cord.
conus, for the conus, for Kodak-Weiner syndrome, some surgeons are using MEPs for L5S1 level specifically because they're the published data that motor evoked potential could really
And
help.
then there's also monitoring the anal sphincter.
Anal sphincter, absolutely, for thoracic cases, for Kodak-Weiner syndromes,
Or conus.
for yes,
Conus is the
yes,
distal
all this
part of the
correct.
spinal cord, the
So
end of the
as
spinal
soon as that moment when we involve motor system monitoring, anesthesia should be changed from say 0.5 Mach of inhalation agents to a TIVA.
Well, what can't you give for motor evoked potentials? Like, in other words, what type of anesthesia can you not give to basically allow you guys to do an accurate motor evoked potentials?
Current literature suggests that we can get MEPs with any anesthesia.
But not a muscle relaxer. Right?
Yeah, we can get with any
Or
anesthesia. However, the interpretation, given that anesthesia affects synaptic transmission most of the time, when you have high inhalation agents on board, the interpretation of your results is very complicated.
So you try to avoid
MEPs.
inhalation
We
agents
try
when
to
they're
avoid inhalation
for
agents
motor evoked
for
potential.
motor
When we
evoked
do a cervical laminectomy, do you guys tell the anesthesiologist, or we talk to the anesthesiologist, and not to give the inhalation agent?
And another component that Dr. Obedian just mentioned, muscle relaxant. It defeats the purpose of motor evoked potentials if anesthesia relaxes the patient, so we actually cannot monitor end of the pathway, the muscles.
But sometimes that's the problem because we don't want the patient
Yeah.
bucking or waking up while we're on the spinal cord.
Right, but they have different muscle relaxant, short-acting, long-acting, and possibility to reverse on time. And at this moment, we're coming back to a communication between surgeons, us, and anesthesia team, anesthesia crew. So we're working as a surgical team, communicating what is happening right now on the surgical side. What do you need at this very moment? And then anesthesia is able to reverse muscle relaxant, and we can get our motor evoked potentials, rebaseline, and continue on. And that will add a great level of safety for the patients and great level of assurance that everything is okay for our surgeons.
So you really need a baseline before you start the operation to really know if
Absolutely.
anything's been changed, because especially during positioning, the patient is asleep. They can't tell us if their arm is going numb or their leg is going numb. And so we really rely on
It's very helpful.
on your interpretation to know if we've injured even like a peripheral nerve, an ulnar nerve, and their arm is going numb for whatever reason, and that can be a very devastating complication in somebody who goes to sleep for a cervical laminectomy, and now they have an ulnar nerve injury. So we've prevented that multiple. I found that to be very helpful.
When you're positioning a patient for, let's say, a lumbar case, the patient lies pretty much on their elbows. You have to pat it well. So oftentimes you'll tell us that there's a problem with the ulnar nerve and we have to reposition it. So that's very, very
But
important.
also when they have severe cervical stenosis, they're myelopathic. Sometimes if you hyperextend their neck a little bit, you can pinch the cord.
So we have to sometimes reposition their neck.
Readjust the head and the neck so that it's a little more flexed.
Again, the baselines is the beginning of the beginning.
Right. So this is where it's really helpful.
Yes.
It's also very helpful when we'll talk about intraoperative EMGs and insertion of the screws, because I find that to be very helpful to know if there's been if you have a low number, if there's been a penetration of the pedicle.
Again, coming back to the positioning baselines, the standard for us is to get the baseline, to report, to discuss it with you and neurologist, supervising physician. And then after positioning, we repeat our data. We repeat our test.
Make sure there's been no changes.
Make sure everything's okay, everything as previously.
Yeah.
Then we give it a little bit time, because sometimes change develops in time, and then you are free to go and start your surgery.
Right. I mean, patients are most afraid of getting paralyzed. That's their biggest fear when they go in for spinal surgery.
And that's what I tell patients when they basically have that fear. I tell them, listen, we're monitoring you to make sure what we're doing during the surgery is safe. That's why we have.
Yes,
and I say that we have a monitoring team that works with us very closely, and that we allow them to tell us if there's been any changes, so we know we can change our approach in real time as we're doing the surgery.
We've been working together for like 16 years, and we've been through many situations. And what is important in our background, in our experience, that every single situation has been resolved.
Can I ask a question? When we do, let's say, for a disc in the neck, we have a patient, we operate, and we do the discectomy, we remove the disc, we decompress the spinal cord and the nerves, we put the interbody graft in, whatever it may be, in a place. So different stages we'll ask for, you guys will say, do you want me to do a motor? And I'll say, fine. We'll say, fine, do a motor exam. At that time, we have not taken the muscle relaxer necessarily off the patient all the time. But at that point, that muscle relaxer, because I remember for sometimes we'll keep it on because we're afraid the patient's going to buck. But at that point, the only way that's going to be absolutely accurate, that motor evoke potential, is the muscle relaxer has to be off.
Has to be off.
Correct.
And that's
we
the
have
thing.
tests. We have.
Do they have inhalation agents on at that point?
No. They should not.
They should not. So what do they have on? Propofol?
Propofol.
So liquid
maybe
anesthesia.
Fentanyl, TIVA, basically TIVA protocol.
So what is TIVA?
Total intravenous anesthesia.
Okay, so intravenous, and what are the components of intravenous anesthesia? I'm asking physiologists what anesthesia is.
And remifentanil.
Okay, so this is the whole thing. You guys know not only about your craft of monitoring. You at the beginning of the case, you guys spend a lot of time putting the wires. These little tiny needles go into the skin.
We'll call it electrodes.
And electrodes, and that's how they monitor. It's not, it's not Bluetooth at this point. It's just they have to, go and put the electrodes in every basically point where it's relevant.
We should invent a wireless.
We should do that. But then, so you do all that stuff. But not only do you know that, but you also you have to know about anesthesia. You have to know a lot about anesthesia and what's needed on board or not needed on board when you do correct.
We have to wear many hats.
Every
monitoring.
syringe anesthesia has affects something we do.
Yes.
So we have to know not only what will affect our monitoring, we have to also pay attention to make sure that they're not doing anything without telling us. This is where the communication
Has that
comes
happened
in.
before?
Happens a lot of times.
They don't like to give TIVA. Most anesthesiologists, they're annoyed by it.
It's becoming more popular for training now.
They have to do more work.
They have to do more work, and they have to be more vigilant.
Nowadays, more anesthesiologists trained with TIVA. They actually welcome.
Is there a higher chance of having intraoperative awareness with TIVA than there is with general inhalational anesthetics? Like they're going to remember what happened in the operating room, perchance, if they don't get enough remifentanil if they don't get enough?
I'm not sure. I think they have enough tools in their backpack to control all of this, because again, as your major goal, our major goal, anesthesia major goal is to make sure patient wakes up safe and with no additional deficit. And so in this case, TIVA would be prevailed over them using some extra components in order to prevent them from remembering or anything else, because they will allow us to do our work, to do our job perfectly, and that will be in accord to your needs.
Sometimes we're operating, and we get told by the neurophysiologist that there is activity in the nerve, at the L5 nerve or the L4 nerve.
And usually it's the opposite side that we're on.
And then sometimes it's well, that's exactly right. We're on the opposite side. How does that, come about? Like, why is there sometimes discrepancies about what we're doing intraoperatively, surgically, and then what you're telling us? It almost becomes not helpful in a way, and almost like distracting. What do you think about that?
Well, there could be a bunch of different possibilities. One, if you're working on one side, it could be putting pressure across, and you may find the other side may be more sensitive. So you could have a little bit of activity because of that. You have any other?
If you can use an opposite side retraction, it also can affect the other side, EMG, and we can pick it up. And
so there's irrigation fluid that might
irrigation,
blood. It can be a little bit of blood there.
But irrigation usually is bilateral. Sometimes patients becoming light, and we can see starting activity on one side, and then it comes on both sides.
I guess it's better to know basically more than not know.
But the question is, at what point, but you report if there's a 50% drop in the threshold, right?
There are certain standards.
There's a standard.
For standards for SCCPs, for example, you report 50% drop in amplitude and 10% extent in latency. But nowadays, literature suggests a dynamic adaptive threshold where we actually monitor the trend of the SCPs throughout decades and then see the major drop, major discrepancy in signals, and then we discuss it with you and supervising physicians.
We also like to know if it's sustained or not, how long it's lasting, because sometimes just by manipulating the nerve and decompressing
that's an EMG.
You may get some intraoperative EMG activity, and we're always alerted to that, and we're like, well, of course you're getting activity. We're touching the nerve right now, and then we give it some time, and don't tell us unless it's
right. And then sometimes that's sometimes when we say that they're like, well, I have to tell you.
Well, again, it goes with the concept that it's better to know something than not. And again, the side goal of our job is to let you know what is happening with the patient.
We can handle the truth. Sometimes you can't handle the truth.
Well, I don't know. I've heard you say things. I've heard you mutter things.
Unfortunately, when you get on the patient's nerves, we have to get on your nerves.
That's a good one. That's a good one.
We try to accept it as sort of background noise. Sometimes.
Well, sometimes we're a little bit annoyed especially when we're inserting pedicle screws, and the patient's a little slightly osteoporotic. And we expect to get a very high number, because what we basically do is we put an electrode on that screw to test it. And you give us feedback of how many milliamps before you get stimulation of that nerve. And if it's less than, and we think we had a perfect screw and, it's less than 10.
Give us a low number, we'll get very annoyed.
We have to check the nerve. We have to
take the screw out and feel and make sure. But it's fine. That's good to do that.
Because sometimes there's a little small crack in the pedicle that we're not seeing, and we can reinsert the pedicle screw.
But that's an additional control for you. That's an additional tool that you can use.
The point of this whole thing is to ensure safety.
Absolutely.
It's another point of safety.
And again, the bone density you just mentioned, it's one of the factors that gives a lower threshold.
Sometimes you a bigger decompression on one side versus the other, so there's less bone.
Exactly.
Or osteoporosis.
Exactly.
Osteoporosis situation.
Yes. So
pedicle screws came into being, really in the 90s, the late 90s, and during our training, they were just starting to become in vogue. And I also remember that we never really monitored the lumbar cases at all. Now everybody monitors the lumbar cases. I think there's a lot of reasons for that. One is that screws now are being used for a standard of care. And also because I think that as time has gone on, there's been an increase in the medical legal world where I think that, if you have at least monitoring, you know that you say, hey, look, my screw was a good placement by the numbers. At least you have that supportive evidence, to always have that documented. And I think that's important too. Another good reason to have monitoring for all types of spine cases, not just for the spinal cord as well.
Well, I'm sure the medical legal aspect of it is important, but I still want to highlight the importance of we providing you with information. When patient wakes up, and God forbid something is not ideal, we provide you with information what actually happened throughout the case. So you can see peg-heel screw thresholds, whether we had EMGs, whether we had changes or not. And that's a physiology of the patient. So that may give you an idea or a hint of how to treat and how to help patient to recover better.
What is an EMG for those who don't
It's
know?
an electromyography that we
And what exactly is that telling you?
Well, that's telling us, indicates muscle activity. We pick up a direct muscle activity from the muscle that may be at risk during your surgeries.
So we know certain nerves innervate certain muscles.
Certain nerves innervate certain muscles.
So you can check that muscle with that nerve.
Yes, correlated with the levels that you're working, and we can provide you with that information.
So L4 is typically tibialis anterior, L5 is typically EHL, S1's gastrosoleus.
Absolutely. So you know the anatomy.
So that's what you're testing.
And you have a little electrode in each muscle group.
Absolutely,
So
yes.
it takes time. How long does it take you typically to set up a typical lumbar fusion case, like an L4-5 laminectomy fusion in the operating room?
It could
Charlie
range
can
from.
do it in no time.
I can do it in under 5 minutes.
Okay, that's pretty good.
You can name that tune in 5 minutes.
There you go.
He's excellent.
That's
I
why
want Charlie in
he's-
all of our cases.
Well, we
Some
don't always
cases
get that.
require a little more of a setup. If you're doing a more extensive surgery, you want more muscles. So that takes a little more time.
About the upper
to adjust.
extremities.
Upper extremities usually take a little more because you have more muscles involved. If you're doing a cervical, you're monitoring motors involved too. So you have to put electrodes in for all that. So you're controlling basically from your neck down to your hand on both sides, but also going to the legs too.
How do you differentiate in terms of your monitoring motors from sensory? How do you, you put the electrodes on, but does the motor and the sensory information come from basically that particular electrode? Or do you need special electrodes or anything to monitor motor or anything different?
They're typically all the same. If you're doing a cervical, you're probably involving from head to toe 50 different electrodes at one point. If you're doing a lumbar, it may be less, and maybe in the mid-20s.
So a motor, as opposed to a sensory evoked potential, a motor evoked potential, you're stimulating that brain, and it goes down the spinal
Yes,
cord
we're
to that
stimulating.
muscle.
You're putting a pair of electrodes.
So it's a different pathway.
Correct. You're putting a
That's
pair of
more
electrodes
anterior.
over the motor cortex to elicit a signal that goes from the brain down the spinal cord, out all the nerve roots. And you don't want to just do the ones you're working at. You want to make sure you have a control for everything. If you want motors on a lumbar case, we're going to do all the lumbar roots. But you want to control. So we typically throw in something in the hands, because if we lose motors in the hands, that's probably not something that you did. That's more
Positioning
either
of the
anesthesia, positioning, just could be technical, could be something wrong in the circuit. So you need to do a whole pathway to assess everything across the board.
Or you got to do some troubleshooting before you alert us.
Correct. So I'm not going to come
It may
right
not
to
be
you.
something that happened intraoperatively. Maybe that the lead got loose or if
Yeah, absolutely. And
And
we
you
can
guys
test for
usually
that.
know you can troubleshoot while you're there with the neurologist. You're going back and forth
At
discussing
one point, we're having 3 different conversations at the same time.
Now-
I'm talking to anesthesia. I'm talking to my neurologist. I'm talking to you guys.
Now, generally, I mean, because when we were alluding to earlier, when we were first doing these, we were only doing SSEPs, and motors came later. And the reason for the wake-up test was that, could you have a change in sensory and still have your motor be intact? How often do you see that? Or vice versa, have a change in
Like
motors
if you have a
and the sensory
catastrophic,
be-
spinal cord injury from whatever is being done, a vascular event or a traumatic event of whatever was being done to the surgeon has been is doing, and you have sensories intact but no motors, or motors but no sensory. Do you ever see a discrepancy like
yeah,
that?
all the
that
time.
happens. Motors can be changed easily if they vascular
Are
event.
motors
and
more sensitive than sensory?
And anterior circulation, anterior spinal cord artery.
Are motors?
That's
It's
it.
a
That's
different
motor.
arterial supply to the anterior
Absolutely,
cord versus
that's
the
a
posterior
separate.
cord.
That's what those
blood
SSCPs
supply.
and MEPs can test for that as well, and it happens.
So you can have a catastrophic change in motor,
MEPs, yes, and
and
SCPs
sensory is totally
can,
fine.
totally fine.
It's probably rare, though, I would think.
It
Not as-
happens.
Not as rare as you would think.
Really?
It happens.
Is it more rare to have SSCPs gone and motors still intact? Because I would think that's the more
That's rare.
dorsal
I mean,
part.
usually MEPs follow.
MEPs follow sensory. So if you lost sensories, you're going to lose motors too. Is
Very
general.
often, yeah.
Typically, yes.
Okay.
Very often. So that's why multimodality monitoring is a thing now.
It's like a belt and suspenders,
Absolutely.
having both the SSCPs and the MEPs.
Back up each other. Back up.
So as soon as you lose one, you want to keep a close eye on the other one to make sure that you don't have
Also,
both.
does it help you decide if it's real, the way changes you're seeing?
Absolutely.
You can.
If you have changes in SSCPs, but the motors are fine, makes you wonder.
Well, usually what happens is, say, we see something in SCPs, we check motors immediately, and vice versa.
Now, what can be the danger of checking a motor evoked potential? Like, what do you have to do? What's the preparation? Because you're basically, if you're doing inducing a motor evoked potential from the brain, can you induce a seizure? Can you cause the patient to bite their tongue? Can you cause any problem?
Yes, you just mentioned very right things. Bite block injuries, seizures, a part of the risk.
So a patient has a history of seizures.
We're trying to avoid.
Try to avoid
However,
motors.
again, that it all depends on what you need to do. So we have to evaluate risk benefits. We have a ratio between risk benefits. Sometimes anesthesia can keep the patient on Keppra and prevent seizing, and we can do very moderate stimulation, and then we will be able to get you through with MEPs, and you will have the information about the motor system of the patient.
So when somebody with a seizure disorder, the fear is if you do MEPs, you're going to induce
They
a
will
seizure.
go into, yes,
and you
that's
can't
a fear.
stop it.
We can't stop it, but again,
You should be able to stop with
based on-
Valium, or there's got to be some way to stop the seizure.
they usually
General
put on
anesthesia.
Keppra. Yeah, that's
Knock them out.
Yes. Very often, patients coming with tumor-induced seizures for the brain surgeries, and that's another conversation with the surgeon, anesthesia, and that's separate preparation for that. And so entire team has to be ready for a seizure event if surgeon choose to do motor evoked potentials for that procedure. Another risk is tongue bites. For that, it is necessary to have a bite block. And bite block are certain...
That's the
should be
anesthesiologist's
that's
responsibility.
anesthesiologist, because it's also prevent an airways. So that's
Prevent a what?
the airways. The
Airways.
airways, yes.
Airways.
And so they have to place the bite block in a certain way. And in that case, we can help them. We can consult them how to do it. We unfortunately are not allowed to place the bite block. So it has to be done by anesthesia, but we can suggest how to put it so it protects the tongue the best. So it's very
And-
important.
and it's not
very
just the
important.
tongue,
It's
too.
devastating injury.
So lip.
If somebody
The lip,
bites
the
tongue.
breathing tube, because you could bite down,
You could break the breathing tube,
Yes, and that would
or
be
or your teeth as well.
compromise your airway.
Because we're sending electrical stimulation, so you generally have like almost a jolt to your body when that happens.
But we see the patient when
try
you do
to-
a motor, they jump.
Yeah, we try to minimize the jumping, but unfortunately, it can be more sometimes. So you want to keep everything almost extra padding even in the mouth, so that when they put that in, it keeps them from breaking their teeth, biting down on their lip, their tongue, or the tube, because you don't want to bite the tube or dislodge it if it moves.
Right.
So you have to keep everything almost as secure as you can.
Now,
Imagine that
SSCPs
in
you
the
run
wrong
all the
position.
time. You don't, because it doesn't affect any kind of motor activity generally.
There's generally a little twitch. It almost looks like they're dancing. You see the hands.
hands or legs.
Twitching a little bit.
Yes,
A little bit.
twitching a little bit. I mean, it may affect anesthesia. if
What
they
is more
have-
important in terms of monitoring for the lumbar, SSCPs or EMGs, do you think?
50-50. Can't do one without. I wouldn't want to do one without the other, because it's telling you two different things, both of which are going to be at risk with where you guys are.
I always thought of the SSCPs as being a better way to monitor the spinal cord, and the EMGs,
EMGs are
better
more
monitor
nerve-
the nerve
Correct,
roots.
So because you're working on essentially in both, you wouldn't want to do one without the other.
And the EMGs are being run continuously as well?
Correct.
Yes, continuously as well.
So I just want our audience to understand how, first of all, how attentive to detail these guys are in terms of setting up and what they monitor and what they're looking at continuously in real time. We also noticed that you guys also show up in the morning before the patient goes into the operating room. And why do you do that? Besides getting the consent of the procedure of the monitoring.
Well, our job involves lots of things. Well, again, we have to meet with the patient. We have to take a look at the patient. We have to evaluate the patient, see what symptoms the patient has, the weakness, numbness. Can they lift the arm or leg? They can move toes.
Because we'll often ask you guys in the operating room, do you remember what side
Yes.
the patient was complaining of pain on? Because
Exactly.
sometimes we'll not have that information right in our minds at this time, but you're the guys that will ask, not anybody else, because you guys actually talk to the patient before the operation.
Yes, we actually do.
And you know what's going on with the patient. And that's
And
very
we would
important.
like to know whether they have diabetes.
Usually we want to
or not.
confirm or
But that's very nice that you
Yeah.
guys know that, and then you guys leave after the procedure is the patient's clear. Do you guys stay with the patient till they wake up to show that your monitoring was accurate, and if you're saying everything was fine, to prove that?
Yes.
So you see the patient weeks or months in the office ahead of time. So you have your assessment then. We don't have that. So when we show up, we do all that testing for us usually before you guys get there. Also, when we set up our equipment, all this is done on a nice little 50-pound machine that has to be set up with everything going from our table to the bed ahead of time. Can't really do that easily once the patient's in the room. So all this takes about a half hour to an hour.
And then you've got to talk to the surgeon, see what he wants, talk to the anesthesiologist,
Correct.
make sure they're on board. There's a lot of preparation that goes into this.
And
So
you guys
by the
stay,
time
you guys stay till the end. You guys are there till the
Once
end.
the surgery is complete, when you guys may hop out, we have to wait till the patient's completely
Awake.
finished with the surgery, drapes are off, take all the monitors off, have anesthesia wake them up, and then do that post-operative test to make sure that everything is still okay.
So that's pretty amazing. You guys are not quote unquote MDs, but you do a lot of patient care.
It goes a lot more than just getting on your nerves and we have to tell you something.
That's right.
Yes.
And I just want everybody to see that with the comprehensiveness of our monitoring company is and how attentive to detail you guys are.
And Dr. Obedian takes all the preventive possibilities to actually correct what's happened. We're increasing blood pressure. Maybe there is something they have to undo. And with time, the potentials recover. So the patient wakes up fine, but the change was real. And you as doctors did everything to not allow this change become a permanent deficit.
Right.
And that's where the value of monitoring comes in. So once we see the deviation of the baseline, we inform you, and that's your decision whether to work on it or say, no, this is something we did, we know, we're aware, we continue, or to work and prevent it become a permanent
Well, that's where your
deficit.
judgment comes in.
Right.
We've been doing this for a long
Exactly.
time. So if we see activity of the EMG while we're on that nerve root, we're not surprised.
And that's again, I mean, this is where
We
we
would
think
rather
it's
have a
positive.
false positive than a false negative.
Well, I don't like false positive because sometimes we like saying, "Oh, you have this, and this."
It's annoying,
and
but,
it's
it's
but,
crying
but
wolf.
still, I'd rather
I
you
don't
tell
like- it's
me
a crying
that
wolf,
that
correct.
there's a constant EMG activity on this nerve, and we just can't see why. But yet the patient wakes up and is completely fine and has complete motor function. So I'd rather have that scenario
Dr.
than you tell me
Sonstein,
everything's fine, and then the patient wakes up with a weakness of their
mean,
deltoid.
very, very often when we say something, you guys do something too. You pause, you
We
give us
kind of
chance.
complain a little bit.
Right.
Listen. I mean,
We scream at you a little bit.
we generally don't have a problem putting our pedicle screws in, but if a pedicle screw were to go awry and injure a nerve root, you would know right away.
We will know.
You'll know right away.
We will know. And it's a very
Our
short
changes are much
period
more
of
subtle
time.
in nature.
It's
We
a
haven't done
very
that, thank God.
short period of time when the screw touches the nerve and it becomes really badly injured. Very short. So that's important where we actually monitor. When you're placing the screw, we monitor it and we see whether that's an EMG or not, and then we stimulate the screws. And so you have this short time window to actually
Remove that
correct.
screw.
correct, remove, and readjust
Although
your
the
plan.
damage may be done at that point. Who knows?
Well, then you know that it may happen, so you have a plan for the recovery, for the post-op treatment.
Yeah.
So
You actually
it's
had that
all about
happen.
information.
One time when you had prepped the hole and you put the feeler in to determine if everything was okay, and every time you poked down, I saw one spike.
Right. So it can
And
happen.
It can,
Happen. So we don't put it. We don't use that screw generally if that's.
but that one time is all it takes.
Yeah.
Yeah.
So it's good. It's good to have. It's really. It's. I think it's a standard of care now, especially on Long Island, to have
It's the community standard to monitor.
to have monitoring on all spine cases. Essentially,
Yes.
I don't use them for kyphoplasties, although I know some surgeons do. I do my kyphoplasties generally under IV sedation, so the patients are very arousable, and if you are injuring a nerve or the spinal cord, they will. We haven't had that happen, but I'm sure they will start moving and let you know.
I think also I want to bring out the fact that you guys do a lot of monitoring for us, obviously, in our practice. Dr. Obedian, although he's not in our technically an NSPC, where you guys are a part of,
Friend of the family.
he's a very good friend of the family, a brother, a bro.
Spine brother.
But nevertheless, I just want to impart that it's not that common for a practice to have their own monitoring company to provide that kind of care and that level of care. And I also wanted to, in the time we have, to mention some of the other types of monitoring you guys do and how as time has gone on, you guys have expanded your services to not only, spine and brain, but also other services, general surgeons.
General surgery.
So you do a lot of monitoring for other groups and other surgeons, not just spine.
Orthopedic surgery, like total
Orthopedic
hips,
surgery.
ENT.
Like, what are some of the other things you guys have
ENT
monitored?
ear, nose, and throat.
Yes,
What are,
absolutely.
give, like
Thyroid
some of the
surgery.
just tell about some of the stuff you guys do in addition to monitoring for spine surgery, just so everyone knows.
Well, obviously, brain surgeries, microvascular decompressions, brain tumor resections. We're doing interesting surgeries in Mount Sinai, where we placing craniocervical fusion with the screws that. Actually, the technique and stimulation of the screws we developed with the surgeon who is doing that, which is, I think, it's a good achievement for our group.
You're checking cranial nerves
Yes, the 12th cranial nerve, 12
for the tongue.
for the tongue. Yes,
This is for the Chiari type surgery.
the Chiari type.
Yes.
Yes. That's very important.
Craniocervical fusions in the last.
Yes, and we're certainly doing some procedure with thyroid surgeries.
What do you do for thyroid?
Charlie?
You're basically monitoring the vocal cords as they're
Recurrent
working
laryngeal
up
nerve.
against the recurrent
Do you
laryngeal.
monitor that on ACDF surgery as well?
You can.
Why don't we do that?
We should.
Can we?
Yeah, absolutely.
Easy?
The tube. Yeah, we have.
So we don't
tubes
even do anything
that we
different for that. The breathing tube that anesthesia gives has monitors on the base of it that go right up against the vocal cords.
So it's just the breathing tube has the monitor in it.
Yes, we connect
Is
it.
that
and
standard of
we-
care? Do they have that at NYU and St. Joe's and
NYU
system?
has it. I'm not sure if like the smaller community hospitals have it, but most of the bigger hospitals.
Well,
have
the
it stocked.
tubes and equipment for that, every single hospital does have.
so it's something you can just put on?
It's by surgeon request. It depends on the surgical
All right, we
technique.
want to request that
the
for all of our
retractions
ACDFs, I would say.
And so we're also monitoring carotid surgeries for.
It's a very rare occurrence to have a vocal cord palsy
So
anyway on
I-
ACDFs.
It is,
regardless. But it's nice to have.
No, it's nice to have. It's nice to have. And so basically, we expanded for 15 years. We expanded a lot. We
You have a tremendous
more than 40
business.
surgeons we monitor.
How many surgeons total do you think you monitor for?
Over the years, more than 40.
40 surgeons. Okay.
But for like total hip replacements when there's bad dislocation and they've got chronic congenital dysplasia.
Right, monitor the femoral nerve?
Monitor the L5
we
nerve.
never, we never monitor that. We didn't have experience with such procedures, but I've
Good.
seen literature describing.
Actually, before I
describing
came
that.
here, worked with a surgeon who monitored all his total hips.
Yeah.
So it was basically he was trying to do it as a study because he wanted to determine the approach to where he was going. If one way did more or less damage.
Like an anterior approach versus a posterior approach,
Correct.
for example.
So he didn't
How about
want to. He
pediatrics? Do
was
you
wondering
guys
if
do
he would stretch
pediatrics?
out nerves going certain
Pediatrics,
ways.
specifically at NYU with Dr. Saris, we do lots of more and more pediatrics.
I actually did a pediatric case last night.
Yep.
Pediatric
For the
case
Chiari, right?
For
You did.
Chiari.
For Chiari,
How old
yes.
was the patient?
15?
15, pretty young.
at Mount Sinai
No, at NYU.
NYU.
at NYU.
What were his symptoms before? Headaches, dizziness?
Severe headaches, a little balance issue, but it was mostly for headaches.
Interesting.
We're also doing scoliosis for Northwell as well. So-
Scoliosis, which is
Yes.
typically teenagers.
Is that who's
young
still
people.
doing wake-up tests, the scoliosis surgeons?
Well, thanks God, we never experienced that, but we
You haven't
spoke with the
experienced that.
surgeons, yes, and with the surgeon who is performing those surgeries, and yes, it is in his toolbox.
Yeah, it used to be a question on the orthopedic board exam. What
If
is
it's
the gold
necessary,
standard
he's
test?
ready to do it.
Was wake-up
Yeah.
test.
Well, I think that we've covered a lot of ground here. It was lovely to have you guys here today to talk about what you guys do and how you provide safety for our patients.
Thank you.
Yeah, thank you for
It
coming.
was a
Pleasure being
pleasure.
here.
You guys are
to be
quite
here.
skilled. We've gotten to become very good friends, and we enjoy
You're
having.
part of the team in the operating room.
We enjoy
love
having you guys in there.
We like the operative banter.
we
Sometimes we
like-
talk to you guys and
We like to
get your
work with you
opinions on
guys.
the world.
No, it's a very nice relationship that we've developed, and I think that's very important. Also, is that you have when you work with the same people over and over again. I think that really provides the best kind of service and care.
And
for
then
patients.
also like not realizing that we have a neurologist behind the scenes, that if we have any question that we're not sure, we can't explain what's going on, there's a third person we can call in real time and get their opinion as well and see what they think and what their suggestion is. Sometimes that's also very helpful.
And this neurologist that actually working with us has been with us for 15, 16 years
Yeah.
too. So he knows what you do, what's happening in the operating room. He used to come to operating room to set up surgeries.
Yeah.
And he is very good at what he's doing, very respected in the community. So
No, we're glad to
It's a
have
good team. It's a good team.
our neurologists on board and everything, and we will continue to work with you guys and continue to have as safe a surgery performing that we do on patients as we can with your monitoring skills.
thank you, and,
And,
we'll continue to
You know what I've
provide
noticed?
the
I've noticed that there's a lot of chiropractors who become neurophysiologists. Do you have any idea what that is about?
It's like a sort of like almost like a step.
Like a step, like you were a chiropractor for a while. You were, I guess, they were into nerves.
They know the nerves.
Fine.
Spot chiropractors are
So
very
you
good
spend
at
a
the
lot of
nerves.
time understanding
The anatomy,
You've had,
the
you've had
nerves.
audiologists become
audiologist
monitor,
because well, it's again
technicians.
basic scientific training, basic training in anatomy, ability to read images for MRI or X-ray. So it brings them to a point where they can apply their skills not only in the office, but also in the operating room, and so they.
So if somebody were to want to become a intraoperative monitoring person, they would
They need a college education.
They need a
number
college
one.
degree.
Correct,
would be
yes.
good.
It would be good, but it's not required.
Now it is.
It is
No,
required.
it is
It is
required.
for
Okay.
the test, yeah.
Okay, so they need a college degree as a minimum, and then they would apply for a job through one of the IOM companies, such as your company. You would train them.
We
You
will
have a,
train
you have a
them.
training process, and while they're being
And
trained,
then-
they're being paid.
Yes.
They're being paid, so they're a paid employee while they're being trained, and they do 150 cases, and after do those cases, they can then sit for the
For the
certification
test,
exam, and then
certification.
their pay will go up
Yes.
theoretically.
And then technically, when they're qualified, and at that point, you still oversee
We're still
them.
supervising
You
them.
still supervise them.
Yes.
Until you really
Yeah,
are.
but even with Charlie, when he sets up the case and I appear in the operating room, it starts, oh, Charlie, can you try this? Can you try this? Can you try that? And Charlie gets mad, kicks me out. But yes, I mean, usually this what happened because it's always good to have to
and not only that, you guys work kind of odd hours sometimes, don't you?
Well, sometimes emergencies happen in the middle
You
of the
guys,
night.
you
They gotta
guys
be on call.
working not only on
On call
weekends,
is-
but in the
yeah,
middle of the
on
night.
call
There's really
does
no off
exist.
day.
We try not to do that.
Yeah, we don't usually bother you too much on weekends
We
or
try to
nights.
avoid working on evenings and
We
weekends.
like to be done.
I think,
Jewish
I
holiday.
think
by
we've
5
only
o'clock.
had one late night case together.
Yeah, it's pretty rare.
I remember that.
Yeah.
But you guys are
I
on.
mean,
You guys have
occasionally you got to do what you got to do.
you guys
so
have a
we'll-
call
we'll do it.
schedule. You guys were called
We do.
in on weekends.
We have a call schedule for weekdays. We have 2 people on call on the weekends and holidays. So we're always ready to help the surgeon.
And you guys also not only work on Long Island, but you guys go into the city, correct?
Yeah,
Yes,
we're in
we-
the city as
we
well.
do.
You go to Mount Sinai in the city.
Mount Sinai West and Morning.
And do you go to
NYU's.
Northwell or NYU in the city?
No.
No,
But
they
we
have- they have-
credentialed and we credentialed at Northwell at Lenox Hill.
At NYU in the city, they have another group that
They have an
I
in-house
think so.
group.
Yes.
they have an in-house group there.
I mean, most of the hospitals do have in-house groups and do have several intraoperative monitoring companies providing the service. So it's a really choice of the surgeons.
It's a growing field.
Yeah, it
you
is
know,
growing field. Yeah.
Because, like I said, 25 years ago, it wasn't that common for every case. Now it's
And it wasn't that advanced
more
too.
standard of care, and there's been advances in technology. Do you see any advances coming in the future? I mean, you seem to
Like wireless monitoring. Do you have
the
anything
cutting
like
edge
that?
of.
It's trying. There's some research on that. Maybe.
I mean, can you put a little like sticker on the patient's muscle group, and then that sticker has a little, electrode in it or whatever, or a monitor, and then that gets monitored, or the signal goes back to your little console there in the operating room. Has that ever been done or that tried?
Not yet.
Not yet.
Not yet. I mean, again, some research. I do believe there's studies on pigs, but
Because that would be amazing if you could get rid of the wires.
It would be. Unfortunately,
There's no mass implementation yet.
Unfortunately, there's too much noise in the room that the signal gets distorted when you try that.
Yeah.
So until you can perfect that,
Maybe with AI, things will change.
maybe one
Well,
day.
AI
Quantum
is interesting.
chips.
Well, I
things
wonder
like that.
if AI were to come into place, would you still need I guess you always will need a neurologist in the background to
Interpret the
advise,
that.
interpret the
AI
Of course,
results.
cannot-
AI will interpret the results possibly more accurate than you.
They're talking about AI
AI
replacing doctors in the future. you
Oh,
know,
well, that'll-
radiologists.
I
I'll be
hope
long
not.
gone before then.
That would be a major nightmare of Isaac Asimov. No?
It will be a major nightmare.
Yeah.
I think our personalities bring a little bit to the table that you can't replace.
Well, some are better than others.
well, again, I mean,
We do have our favorites. I mean, we're not going to tell you who they are, but we do have our favorites, and we certainly favor you two. But
Oh, would they-
We have to imagine AI cannot set up the patient. AI cannot provide a good communication between surgeons and anesthesia. And I think AI would be very helpful for supervising physician,
for interpretation of
algorithmic,
results,
for,
and
like-
give you an alert.
not even interpretation, but
like a check and
probably
balance.
the check and balance. Yes,
Yeah.
that would be
Help
very
you
nice.
troubleshoot before you notify the
And
surgeon.
in the operating
the
room,
lead, check
it
this.
may help actually tremendously to help the technologists to troubleshoot, to discriminate the problem. But again, that AI has to be trained. That I don't know how to say this.
We should come up with some kind of software we can become the AI.
Several
for
companies,
intraoperative
several
monitoring.
companies are working on it.
That's okay.
I'm going to
got
devote
an
all my
idea.
time to that.
That's our
Several
that's
companies
our
are
next
working.
step.
I'll
which
leave
makes
it. I'll
sense.
leave it to you guys to develop that.
One day.
All right. Well, anyway, this has been great. Thank you guys so much for coming. We really appreciate it, and we will enjoy
Look
continuing.
forward to
working
seeing you in
with
the operating room in the future.
Yes, tomorrow.
Thank you. Thank
One
you.
of you guys.
Yeah, perfect.
Thank
We
you.
we like all you guys.
Got an ACDF, and we would like to monitor the recurrent laryngeal nerve.
Yes, we'd like to try that. Thank you.
Very good. Thank you.
All right.
All right. Thanks very much.
Very much.